County, and I am excited to help lead the general meetings.
Carrie, I am going to stop you there.
Yeah.
And putting it on speaker view.
Okay.
And I'm going to click record.
Okay.
Hold on.
Yeah, I just clicked it as well, Twyla, but go ahead.
Oh, it's recording. Yep. It's
okay, good.
Okay. So now we are recording. So again, my name is Carrie Du Bois, and I am a board member for NAMI San Mateo County, and we welcome all of you to our general meeting. I am thrilled with the panel that we have presenting tonight. The topic is the role family members can take to support a loved one with mental health struggles. One of the things that we're doing tonight, we're taking the topic of mental illness a little broader, because we know that as family members, we deal with a broad spectrum of issues. So we will be touching on major mental illness, dual diagnosis, addiction. So we hope we will cover the topics that you all are dealing with. So I will do a brief intro of our speakers, and we are devoting most of the time tonight for their content. They have a lot to share. And towards the very end of the meeting, our timing is from 7 to 8:30. So towards the end of the meeting, we're going to be allowing about 10 minutes for questions. The chat will appear and your questions will come to me, and I will select as many questions as I can. We will not be able to probably answer all of your questions, but we will do the best we can. And then to wrap up our meeting, our executive director, Twyla Dependahl, will do our closing remarks. So on to introducing our panel of esteemed people who are here today. First, we have Dr. Rick Chinchinelli. He is a psychiatrist in private practice in Redwood City. He serves as a staff psychiatrist with Bay Area Community Services and works with the Meadows of Arizona that recently opened an intensive outpatient program in Sunnyvale. He's also the medical director of Embodied Recovery in Los Gatos. Our second speaker is Dr. Jennifer Harrison. She is a board certified licensed clinical psychologist and a board certified art therapist. She holds a diploma distinction at the National Center for Crisis Management, and she's with the American Academy of Experts in Trauma and Stress. Our third speaker is Connie Swanson, MFT. She is an associate therapist in private practice. Connie is passionate about treatment of addiction and trauma. As a relationship builder, she works with individuals, couples, and families to advocate for recovery of family life. So thank you again for giving us your time tonight. So we are going to start with Dr. Chicinelli.
Oh, okay, let me start again. Today, I had been seeing a patient who is living with his parents. He's 27. He had been in the hospital last year, psychiatric hospital, and he then went to a program and then is now in a program but living at home. And I asked, well, how's it going at home? And he said, going well. I says, well, would you believe it? Tonight I'm speaking at a NAMI meeting. Is there anything you could give me as far as advice, as far as how it works for you working with your family? And he says, and this says the whole thing, mutual respect and follow the house rules. And that is, that brings up what can we do to serve our loved ones who are who have mental illness. And there's all kinds of questions like what's going too far, what's not going far enough, how do we help them when they don't seem to appreciate it? There's so many aspects to it. And I would like to give a little history tonight of why we're faced with such a difficult thing, being supportive of our family members with mental illness. And it's good sometimes to sit back and kind of wonder where we came from. I mean, there were the days, like from 1900 to 1960, where the only thing we had really in general was people in institutions and people in psychoanalysis. and there wasn't very much in between. And because there is such a revolution in the 60s and 70s, maybe starting in the late 50s, of new things, therapies for the people, so to speak, without having to be in psychoanalysis, and the thought, and this was an ideal, that potentially patients could be brought back to the community to be integrated and not have to be living somewhere for the rest of their lives, isolated from everybody else. So there was a patronistic sort of side to that, in that some people did get pretty good care, but it was like there was not much we could do with chronically mentally ill people except house them and be as benevolent as possible. So then, it hasn't been that long. So in the 60s and 70s, here comes psychiatric medications. And there was so much hope in them because, hey, we could medicate people who have these chronic mental illnesses, and they could respond sufficiently, possibly, to come back to the community and be treated there. And the idealistic part, in fact, it was President Kennedy who signed the Community Mental Health Act in 1963, where it was just so much hope that we could integrate people into our communities and serve their needs, and their needs would be met. So what happens? Well, as usually, as idealistic as things can be, we didn't really have then the sufficient resources, money, programs, or outlines on how this could work. So when I was in training, I think they had community mental health centers where there would be like group therapy and individual medication, management, and the patients would have to kind of find their way there, and if they didn't want to, they were lost to follow up. And so it would take a motivated patient, to be getting care. And so I worked in the crisis unit, my first experience, and there were multiple crises all the time. People come in and extremely agitated. And we did have the medications to calm them down, but we didn't have the resources to really meet their full needs. We would blame when I was in patient work, we would blame the outpatient therapists for not doing their job, because we would be then bailing them out when the patient went into a crisis. So what happened over time is that people began to think, well, what can we do to make these services for mentally ill more comprehensive in the community? And so eventually, people may remember Prop 63, the Mental Health Services Act, which was a model to provide more comprehensive care for mentally ill patients that would really meet their needs, from everything from vocational to housing to case management support, to seeing the psychiatrist and going on social outings and teaching them how to do activities of daily living and becoming independent as possible. And I have worked for these kind of organizations the last 12 years in the East Bay. And it's sort of like, I've been really inspired by it because we didn't have it before. And it's literally being out there in the community, meeting the needs of the patient. And, but even then, it's still like there's so many places that patients can fall through the cracks. obviously the biggest one is the criminal justice system. And there, I don't know, excuse my dog making a noise here with the, drinking the water. So the patients that would be found in jail and then mentally ill, there really wasn't a place for them. They would have to, they did not get their charges excused. I did a little of that work in the 70s, but it didn't go very far. So they had to really be, to deal with their charges. And so what has happened is that most of the people that were in the hospitals ended up in the prisons and jails. Not most, but probably about half. Yeah, I don't like that either. At any rate, so that has, there's been all kinds of things though since then that we've done to try to repair that. And that is to have court projects, criminal justice, mental health programs, and ways in which we could follow people and help them get out of the criminal justice system. But then one of the things that was the most difficult, and this is what I think gets families that are trying to be supportive to their loved ones, is that one of the first things in 1967 after the Mental Health Act is that especially in California, the commitment laws were so rigid. So people who, obviously in the community, the chronically mentally ill, they would need brief hospital services from time to time and to be restored back to the community, but the hospitals in the community, but it was almost impossible to get people into the hospitals without forcing them there. And the laws were so protective. This is from, I guess, a psychiatrist standpoint, so protective of the patient's rights, which is good on one hand, as far as like they could not be forced into a hospital against their will unless they were danger to others, danger to themselves, like suicidal, or gravely disabled, where they were just completely unable to take care of themselves on a gross level. So this created another whole set of new ways in which people can fall through the cracks. So there was a lot of people that would get really manic or really psychotic, go off their medications or whatever, and they didn't qualify for hospitalization. They could sometimes if they went in on a voluntarily, but the nature of mental illness is half of it is like is denial. So people really would get ill out there in the community, families, wondering what they could do, and there's no way to get them into the hospital. So this is one of the things I've lived with my entire career. And I've been on, I actually became a little, that's the word, patronizing, as far as I wish there was a way we could help, just get this person help so we could get them stabilized so they can go out again, but there weren't ways to do that all the time. And so then the Mental Health Services Act then that I had talked about before were ways in which to provide more comprehensive services so that people who would need services might have case management and advocates to support them. And then since then, there's been other laws like Laura's Law, which is an attempt for people that are really potentially dangerous to have a higher level of commitment whereby they will be followed. They can't be forced to take their medications, but they can be managed or forced to at least comply with management in these mental health support services. So that has, Laura's Law is not used very much, but the case management model has grown. And I see people with all kinds of problems, not just with schizophrenia or bipolar disorder or serious depression, but a lot of trauma. Where, I never saw this in the past in the community mental health system now. I've seen a lot of people who are misdiagnosed with schizophrenia that actually have a PTSD with like psychotic symptoms. And so it's really been interesting. And I was just hoping, though, that we can supply the people in the community mental health services with the type of excellent services that are going on in the private sector, like EMDR and things that really are helpful. And, I think we'll get there. It's just, we always are catching up to the ideal model that Kennedy came up with, trying to patch it together. And so one thing I could say about about families working with those in the mental health system, it really does help when families are involved. Sometimes parents or family members will come to appointments with the patients, and these patients are really at an advantage to get that kind of unconditional support and care, in addition to professional services. So one of the things, though, is with all these cracks in the system and ways to fall through the cracks, I mean, how is it that, how can families really be helpful? This patient I saw today, that was unusual, where he was getting along with his family. He might get psychotic at times, but somehow they coexisted, and the family's help was tremendous. And I noticed that those that have families helping really do better. Unfortunately, though, there aren't that many patients that have that I see in the community that have such families supporting them. And then when it comes to how the families support, and this I'll probably leave for the rest of the speakers, but it is, this thing with when codependency, the notion of codependency came up in the 80s, we had something like it before, but the new name was in the 1980s. It was like, what we want to help our loved ones, but we don't want to help them in a way which prevents them from getting better, or which serves their self-destruction or negative behaviors. So how can we help them? And that's a story of my life working in psychiatry, helping parents decide, what is reasonable help and support. And I mean, everything from finances to where they're staying to everything. And then what is too much help, which can stifle a person, prevent them from seeking a healthier independence. So this is the name of the game. And I'm being Italian, especially, I'm on the side where I believe in, as much support as we can give our loved ones, by families, emotional support. But on the other hand, people really have fears that if they help too much, that it's going to spoil them or stunt them. And I have stories about that, but for another time. But nonetheless, it's some of the things that I've learned on helping families dealing with their loved ones who are mentally ill is being supportive, and being accepting our limits, that there's only so much we could do, but what we can do is helpful, and to accept what we can't do, and also to accept that mental illness is generally a lifelong condition. There are some treatments that we have for certain conditions where people can pretty much normalize, but we're not there yet when it comes to schizophrenia and schizoaffective disorders. And so the thing is to provide support, but set your limits. try not to give too much advice because they really don't want it. But be, let's see here. Am I out of the meeting? What happened?
Nope, you're still there.
Oh, okay.
You're still there.
My screen left, but okay.
You're good.
Okay, good. So set your limits, accept what you can't do, but be glad of what you can do and realize how helpful it is to your loved ones. I think I'll stop there. I lost my picture. I'll try to get back here.
Thank you, Dr. Chicinelli. Appreciate those
Yeah.
words. All right, Dr. Harrison, you're up next.
Hi. So I was going to spend my 20 minutes here talking a little bit about sort of crisis, the inpatient setting, what happens as we transition to outpatient, and some of the challenges that I think a lot of families face during that time, which is particularly an area that I come into. So I am a clinical supervisor at 2 psychiatric hospitals, the biggest in Northern California. And I think a lot of the challenges that I see with families are really one of transition. So couple things. I think what happens is there is a loved one that is an adolescent, a young adult, an emerging adult, an adult, and they end up in the hospital for crisis stabilization. So one of the things I'm always talking to families about at the hospital is to assure them that they are in a crisis state. So a psychiatric hospital is never going to be a place where you are going to receive any kind of therapeutic care. And what I mean by that is from an actual therapy position, right? There's no space. Patients are in groups and we're trying to stabilize. But as you know, particularly when young people are 5150, and even when that moves into a 5250, they're in a crisis state. And so then the big question becomes, when you're in a crisis state, how do we start to support our loved ones as family members at that state? And lots of things kind of come into place. Questions about conservatorship comes into place. Questions about how one is going to, conversations with the psychiatrist and trying to understand medication. If there has been a risk of suicide, fear and anxiety about that person leaving the hospital, right? And whether or not they will be successful at suiciding once they leave the hospital. Sometimes families do not want patients to come home. Please don't I don't want my adolescent home. I don't want my loved one home. I don't know how to keep them safe when they are at home, which is a really big fear for a lot of families. We don't know what to do. Sometimes in a lot of situations, I find that particularly if the loved one has become aggressive in any kind of way, there's this constant fear of like, if we go to sleep, what's going to happen? Having them at home, the anxiety, it becomes so chronic and so overwhelming for so many families that they don't have an understanding of what to do. So they say, please don't send them home to me. I don't want them. Right. And so there's tries to be this transition of care sometimes to a secondary facility, right? Are they going to go to residential? Are they going to go? Yes, but they need to go to an IOP program. So they're checking in every day, which obviously sometimes can have its own fair share of anxiety. So I think, unfortunately, what happens is you have a family that is in a crisis state where something is happening with a loved one. They are unstable, they are struggling, they are dysregulated, they have been called into the hospital, that's their only course of action, and now they are leaving. And there are so many challenges that happen at that given point in time. Oftentimes I hear families saying we have no discharge plan. We don't know what we're doing once we leave. There's no one's called anybody. We have no therapist. We don't know where we're going. There's who do we talk to? Where do we we feel lost, we feel helpless, we feel alone, and there's no clinical therapist that is stepping in or anyone to bridge those transitions, right? And so oftentimes what happens is families go home, and within 24 hours, another crisis ensues and they're back in the hospital. And this is like this chronic revolving door that happens where families are feeling like they're stuck in a system that they cannot escape, and they have no way of treating their families or their loved ones. Particularly when we're dealing with some of our psychotic disorders, you might get a loading dose of medication at the hospital, which stabilizes, but then what do you do once they discharge? So there's a lot of questions around these kinds of transitions. One thing that I want to say about families is that families are a protective factor when it comes to our loved ones that have mental illness. Oftentimes, I think way too much, we start to think about families as being, triggering experiences or the cause of some of these challenges. Now, listen, lots of people have conflict, lots of people have dysfunction. That's not what this is about, okay? What tends to happen, and this is usually where my team tends to come in, is that families hold the narrative of that loved one. Sometimes when individuals that are dealing with mental illness have no idea about the trajectory of their story, when it started, how it went, where they've been, what medication they've been on, what's worked, what hasn't worked, right? And the families become the holder of that information. And that becomes so necessary in trying to help a loved one with mental illness or anyone that's in the mental health system. I can't tell you how wonderful it is when a family comes into my private practice and has the story about that person. This is everything we've been through. I've been documenting it from the beginning, right? The things that worked. I like to know questions like, what was the longest period of time that you felt like things were okay? Why do you think that was? Right? This is the ways in which we can understand what goes on holistically with the individuals that we are trying to help. This is also really useful as you are trying to transition that loved one into other forms of treatment or care. So, for example, you are likely to find yourself in an IOP program, in an outpatient services program. You are likely to find yourself in a meeting with the psychiatrist in an outpatient capacity. Your first time doing family therapy, any place that you go, it is helpful for the loved one for you as a family member to share exactly what's going on with that person with any facility that you find yourself in contact with. So I really think that one of the rules that family members could do is to kind of type up and organize the story of that person. Okay? It becomes like something that they can share as they go from place to place. Because one of the things that happens in the mental health system, particularly with individuals that have severe mental health problems, is that they end up bouncing around to so many providers, and you're talking to so many people all the time. And sadly, and this is again part of our dysfunction in the mental health system, is that we get cases where individuals have been on this medication, now they're trying this medication, they haven't quite titrated from this other medication. There's so many things that are going on with an individual that oftentimes people that have been in the system so long have to like med wash and start all over again because nobody knows exactly what's working anymore, right? It's quite tragic and sad. Okay, so the goal is, how do we help during this like transitional period? So there's been a crisis that's ensued. It might be their first psychotic break. It might be their first conversations about suicidal ideation. It might be the first that you're hearing about a abuse or traumatic event that happened. Oftentimes family members can be out of the loop, unaware. That makes them feel helpless and sad and overwhelmed. How do I support this person? And they end up going to the hospital. And right now in California, the hospital is our first course of action. We call 911, we feel helpless, we don't know what to do, you go into the hospital. Sometimes, and this happens with adolescents, that is the loop. No one gets out of that hospital system once they're in the hospital system, because adolescents, they get in there and they're like, this is where I feel most comfortable. This is where I feel safe. And they don't want to leave, which is very clinically relevant to us. But after they get out of that system, ideally one is stepping down to an outpatient program, whether it's an intensive outpatient program or an outpatient setting of some kind, or they're going to a residential facility. And that varies based on obviously things like insurance, what insurance will pay for, out-of-pocket expense, etc. Here's the thing about residential facilities. I get this all the time. I have residential teams in my office. We're transitioning this individual back into their everyday experiences. We've signed behavioral contracts. We've done all of these things. Here we go, right? And they come out and there's all this expectation. But in reality, we know that people don't do very well all the time coming out of residential. The reason why it has a lot to do with those stressors. The things that are stressing those individuals, they are removed from for weeks on end, months on end. And when they return back home, they are reacclimated into the stressors. The hope is that they have tools to manage. That's not always the case. So there needs to be this plan in which people go from residential, right, into an individual therapy, group therapy, family therapy, all the therapy experience, so that there's constantly getting support. We want to make sure that we are constantly supporting our loved ones. Okay, and part of that means that we have to understand that family is definitely a protective factor. Part of that looks like accepting shared responsibility. How do we accept shared responsibility? By creating a supportive and safe place. Now, I think sometimes there is some anxiety and stressors about how long we're going to live in this loop, how long this is going to be, is this going to go on? You know, it's a very chronic traumatic state for a lot of loved ones, because there are good days, there are bad days. You know, you can't quite decipher what days are good and what days are bad. I think for my families where the loved one has made an active suicide attempt, those can be very scary. You're not sure what's going to happen. You want them to stay safe. You know, you're constantly checking. You're constantly in a chronic state as well of anxiety. How do you manage that? You get information like lock up all the silverware, or lock up anything sharp in the house, or you get a lot of coaching around what to do, but that doesn't feel like a way of life. Like, this is what you want to do. I think it saddens me when family members miss having a connection to those loved ones. You know, it feels like the world of mental illness is everything that you basically have and that you live in, and it seems to be all consuming all the time. You find that your friends don't relate anymore. You find that this is something that you and your partner are only talking about this all the time. This is your whole world. And it can be very upsetting. It can be very overwhelming for everyone. It's a very much a shared experience that happens when you have somebody that has severe mental illness. For those of you that feel like you can, you have to remember that you have to be part of the center of treatment care, that you are part of the care team. right? And so part of that means that you have got to facilitate and do your best to get involved with as many providers as possible to help support that person. I think that some of the ways that family members get involved are around identifying natural support in treatment, meaning like you can be part of safety planning. You can be part of looking at ongoing care and what that's going to look like, right? You can help create peers, particularly if you know that loved one's friends, and they can be part of the support network that is necessary. The more social and emotional support that happens around that loved one, right, the more we're able to promote recovery. We also have to follow models of care, such as like a harm reduction model, right? Where we're constantly not thinking about if this happens, but when something happens, how do we find ourselves prepared for these situations? I encourage all of the family to be in their own individual therapy, right? As you need to be able to support and take care of your own selves as you're being able to take care of and support your loved ones. I think that at times, one of the biggest issues that I find is there is a lot of pain and anger that comes up when trying to figure out how to support loved ones. Sometimes that gets triangulated into the mental health system, which I will be completely honest, is not a great system. We have a lot of errors. It's a real big problem. I mean, the helplessness that families feel is something that is inherently wrong, with our transitions and our system. And I think that is a national problem. I've certainly experienced these kinds of issues working in New York and in Florida, in Chicago. And so everybody has these similar transitional issues. It's a big problem nationally. I think that also during the care transitional periods, when somebody comes home and no one is providing clinical care, that can increase anxiety as well. And so I think in those periods of uncertainty, to avoid that, it's always important to make sure that you discuss with the inpatient team, right, the hospital, the residential, what the discharge plan will look like. What are going to be next steps? It's okay to advocate for yourself as a family and your loved one by saying, I am not comfortable without leaving without a plan, right? And the idea is that you guys get that plan and that you have contacted providers so that the person transitions immediately into some kind of therapeutic setting. There is so many pieces, I think, where there is fragmentation in the process. And I think that families need to really see themselves, right, as the stable constant that is happening in that loved one's life, right? You are showing up, you are being present for them. You are there to love them and support them as much as possible. You are holding their narrative, you are holding their story, and you are doing everything you possibly can to ensure that there is a successful transition of care as much as possible. Thank you.
Thank you, Dr. Harrison. That was great. Okay, our third speaker is Connie Swanson. And is Connie unmuted? I don't see her on my screen. There she is. There you are.
All right, can folks see my screen in the PowerPoint?
Twyla, could you take that down? I can't.
The PowerPoint?
Yes,
Okay.
just let's not use it. I think.
Okay.
Okay. Thank you for doing that. I didn't realize that I would lose my screen. So it might have puzzled you if you saw that I was going to be adding to this by talking about self-care. You're not newcomers to that, but you are facing extraordinary new requirements, new challenges, and a lot of the avenues that were available for you as you loved the people in your home were no longer available to you. So I have a couple of objectives, and I work with parents, and I work with the 20-somethings. So I hear both sides of this. What I hear from parents is that they are under-resourced, and I'm guessing that most of you fall in the category of being parents. So what I would like to do tonight is talk about self-care in a way that you come to think of it as just as essential as eating food and drinking water. Both of those, of course, are self-care, but we do not think of many other of the parts of self-care strategy that keep our nervous system anchored as valuable as eating and drinking. You are the only one that can do this for yourself. And I would like to give you some portable strategies that you can use anytime, anywhere. So now, as never before, the more you hold, the more you need to be held. The more you hold, the more you need to be held by your communities, this community, the more you need to be held by your own self-care practice. So let's look really quickly at a kind of continuum of self-care. Self-care ideas came to us from 3 or 4 different places. One of those was the women's movement. One was civil rights movement. One was in California, Esalen. So we have a wide spectrum. And some folks are tempted to think of self-care as an add-on or as rather superficial. We know because, and both Dr. Chicinelli and Dr. Harrison pointed out that the work that you are doing is long-term work. So the gain from that we have from the civil rights movement is that they picked up self-care because they knew that their work would not be over. So if we think of a continuum of self-care, and on one side we have rudimentary care. Rudimentary comes to us from the Latin, and it means like the first principles. Well, our human being first principles are sleep, food, exercise. We know meditation is a help. Those might have been the first things that you heard. On the other end of the spectrum, something more radical, where all of those are deeply integrated in us and are a daily practice. So if you think that you are carrying perhaps as heavy or perhaps heavier load than you ever have, the care, the way you are held needs to increase. The writer of Your Body Keeps Score, said that once you can approach your body with curiosity rather than fear, everything will change. This may be true in a big way of those moments that you experience consecutive crises. I have not hesitated when I see parents to notice that what they are struggling with is a kind of PTSD, where their nervous system has really been on overdrive. So let's think about the human nervous system here. And I wish I could do what I need to do here and have my slides, have the slides up. But there's one, if you imagine two parallel lines running across a page, and in between, there's a sort of wavy line up and down. That's the nervous system on a very good day, where it gets activated and the activation wanes, and it becomes reactivated and the activation wanes. What happens to most of us, however, particularly when there are stressors and crises, Dr. Daniel Siegel calls this the window of tolerance. We crash out the top of the window. We can't keep ourselves inside the window of tolerance. And when we crash outside, we're in a fight or flight state that might be familiar to you. What does this have to do with the loved one in your home? Just like we communicate voice to voice with the people we live with, we communicate nervous system to nervous system. You may notice that there are people that you are with, and being with them calms you. You may notice that there are people that you are with and you become activated and maybe move almost to fight or flight, and maybe you do. So we're going to think about ways that the nervous system, that we can take care of our nervous system. How can we settle our unsettled nervous system in the environment, in the home that you're in? So if we add to these stressors a global pandemic, and we find ourselves with unrelenting crisis, we can actually get stuck outside the window on high alert, vigilant. We can also, as our body tries to readjust for that, we can crash through the bottom of that window. And when we're there, we can feel zoned out and numb and immobilized. One of my clients described it to me like this. They said, it's like the spinning beach ball of death that appears on my computer. My mind is stuck, my body is stuck. I just want to pull blankets over my head. So we have a nervous system that we very, very much need to take care of so that we can be with the nervous systems of these kids that we love. So I'm going to teach you a little exercise. So bear with me here. Put your feet on the floor, get them settled, and put your hands in your lap. And bring your attention to your feet. Notice your feet, your legs. Notice gravity anchoring you. And switch off the muscles in your legs. Breathe deeply through your nose. Exhale through your mouth. Bring your attention to your back, to your stomach, to your chest. Switching off the muscles there. Inhale and exhale. Now bring your attention to your fingers, your hands, your shoulders. Notice the tension and let go of it. Switching off the muscles there. Bring your attention to your head, your neck, your jaw. Switching off the muscles there. Now gently open your eyes. I know this is an odd format in which to do this, but I'm hoping that you registered some relaxation as your body began to pause. This is from the Headspace app. It's available in 1, 2, and 3 minute, quick, very quick meditations. You know your triggers, and now you may have an off switch. You can also be a scientist. The educator Piaget said we come into the world as scientists. So you are your own scientist. I listened to a very competent mother. She cared for other people in her work, and she cared for other people at home. And she would mention sometimes that she hadn't eaten all day and was shaky. She had a story that in childhood, she started dialing down her own needs. You may have dialed down your own needs. You may have dialed them down in response to this seeming continual crisis in your home. But she knew about other people's needs. So barely aware of her own, we began a project that we at first just called Dial Everything Up. So dialing up her sense of when she was thirsty, of when she was hungry, of her own body's needs. An amazing side effect of this was that she became a scientist also for the child that she loved so much who lived in her home. And she began to say things like, I see what happens when I remind him and remind him. I asked him what was happening, and he said, I think I'm allergic to your voice. And because she was being an observing scientist, she was able to hear this in a way that she may not have been able to hear it if tempers had flared and her own nervous system was activated. So whatever you do for your nervous system, you do also in your family. Another very portable strategy is your 5 senses. In fact, you can't go anywhere without this. You can't go anywhere without this strategy. So if you're in a car and you find you're becoming activated, let yourself really feel whatever the cover on your steering wheel is. You might say to yourself, I am safe, and really notice the touch texture. You can feel the upholstery on the seat. You might have lavender on your nightstand. The taste of tea. You can always step out the front door or the back door and see the sky. The sky and some deep breathing will often reset your own nervous system. Warm bath and shower, and I know you'll tell me that those aren't portable and you can't take them with you, and I won't disagree, but you get a lot of sensation that can restore your nervous system. Now, the five senses exercise needs to be done with focus, just like being a scientist for yourself or a scientist in your own home. And I hear all the time, I'm doing this and it really works. I do these exercises and they really work, but I get unsettled again. This is just exactly the truth. You get unsettled again. When you eat, you get hungry again. When you drink, you get thirsty again. When we settle our nervous system, it gets unsettled again. I am going to ask, is it Twyla? Twyla, can you put up the slide of the space monster.
Is this it?
Yes. So is from the movie Enemy Mine, played by Louis Gossett Jr. And I teach this to parents. So if you can stay on that slide. I teach this to parents, and I also teach this to young people. You got a glimpse. Did you get a glimpse of the drac? If you just, is everyone seeing that?
Yes, it's back.
Okay, now you can take it down, Twyla. I just wanted everyone to get a look at it. So Louis Gossett Jr. Played the drac in a movie named Enemy Mine. And I use this with young people, and I also use this with parents, because if you noticed, had a really flat place in the front where we think of having a nose. And so all of those gill flaps are used to breathe. And often I will have a young person who is recovering from opiates, and they will need a minor surgery, or they'll need to have a wisdom tooth pulled. And I will show them the drac and tell them to pretend that they have gill flaps all along their jawline. And we will practice, instead of breathing into their lungs, breathing in there. This is good for anyone who is a parent too, because you can be standing at the counter in the kitchen and you can imagine that you are a space monster. And this is how it goes. You are going to breathe in through your fingertips. So much as we did before, just relax and pretend that you're a space monster and your nostrils are in your fingertips. Now inhale deeply and exhale. Inhale again and exhale. I was once listening to a yoga master who told me that this is called breathing into the tissue. So it helps for pain, it helps for relaxation. If you are listening to each other in your family, and you heard from Dr. Chicinelli, and I could not agree more, these connections are so crucial. But if you are listening and find that your nervous system is just about to crash the window, begin to breathe through your fingertips. Bring your nervous system back into that normal rhythm. You may have thought at one time or another that you really would like to take off. You really would like someone else to take care of you. Wow, I've heard this lament. I just want somebody to take care of me. I think we all get it. We all get it. To her surprise, and to mine, a friend of hers said, why don't you come and stay? We have this suite of rooms, come and stay in it, and we will take care of you. She said the first day, the second day were okay. And then she missed her routine. And then she missed all the comforting things that she had built into her environment. And then she missed her own schedule. And then she missed the familiar ritual of her day that settled her nervous system. When she came back, she said, I guess this is kind of obvious, but self-care has to do with where I keep myself. So for this woman who was a nature lover, we added nature. And you may have noticed in Time magazine about 2 years ago, there was a cover story on forest bathing. This has become a line of research in Japan. And the book, Forest Bathing, is now available. The research continues, and they bring people into the forest, giving them a taste of tea that's made from things in the forest. They spend a couple of hours there and they find that it has reset their nervous system. And the claim of this research is that it helps heighten the baseline on your nervous system for 7 days. So if you like nature, even in smaller increments, you know, I had some pictures of sunrises pretty much from my front step, of trees pretty much in my front yard. So you can enjoy nature and know for sure doing your nervous system good. If you can take a blanket and sit with your back against a tree and lean into the tree and feel supported by it, and notice your nervous system. A great gain can be had just from bringing your attention to your own interior. So I've listened to a lot of parents of the love that they have for children who struggle with substance, who struggle with mental illness. And sometimes the focus can shift away almost so it is quite solidly on that child. And I encourage returning a focus to self-care, because then when you're holding a lot, you need to be held. So hold yourself. So it might seem like a fantasy to you. That was my own response when I was sitting where you are sitting. That was my own response, which is why I wanted you to have this list of portable resets for your nervous system. Look at the sky, smell the spring smells, which are here for us now, savor flavors, and make the most of those beautiful moments.
Thank you, Connie. My reset to my nervous system is my herb tea, which I drink a lot of. So thank you. So we do have time for questions. One of the things we're going to do is reset the chat so that questions will come to me, and I will take a look at those and we'll go through as many questions as we can in the time that we have remaining. So I'll start with a question, I think Dr. Chicinelli and Dr. Harrison. For some people in this audience, and many people that I know out in the community, our loved one is refusing treatment. So I was wondering if you could talk a bit about the family's role in trying to guide the person into treatment, and if they're refusing, any strategies for that situation. Are you able to unmute yourselves?
Yeah.
Good.
Dr. Chicinelli, do you want to go first, or?
Realize that it's not just that they're refusing at this moment. It's a process that goes on, and that they will be at other times more receptive. Also be calm yourself and accepting of them without their thinking that you have an agenda. And that will calm them, just like we were hearing about calming ourselves. And lo and behold, you know, people, I've seen so many people where they are resistant, and then a few months later, they're back in treatment, and then they refuse and back. But it's like going along with kind of like something you ride, like a wave, and you learn your balance, and you will gain wisdom as you do that.
So I think that that's kind of a bit of a loaded question when somebody's refusing treatment, because obviously there's different degrees in which somebody is refusing treatment, and obviously safety becomes an issue. So I'll just talk about it from maybe like a lower level of care, which is you know, they won't go to see their therapist, or they won't, you know, stick with medication, or I would say to you, I would say to anybody, and obviously I just also want to preface by saying children are different than adults, right? And so there's a lot of different other agency that's involved. But treatment is not something that can be forced upon anybody. I mean, when you go into the field of mental health, it is almost immediately taught to you that you cannot go out there and save people who don't want to save themselves, right? I teach all my students, we don't wear capes, right? If you want to go into the business of saving people, go be a nurse, right? Go be a fireman. There's other people that save. That's not what we do, right? There is a process of facilitating change in individuals, and that is our guided role. And part of that means that somebody has to come present, ready to at least want to get better, right? And there are so many models around this, from addiction models to therapy models, that talk about, you know, when people are ready. I don't expect anyone to, you know, stay connected to somebody and suffer through it in tandem with them. That nobody wants that. And I think Connie's really trying to stress that in what she was saying. Self-care, how are we taking care of ourselves? But what I do think is important is to say, if not me, then maybe who? If it's not me that can help, is there anybody else that you are willing to listen to and get support from? I'm okay if it's not me, but is there anybody? If it's nobody, right, and you want to be and you want to be alone, right, is there a place that you feel safe being alone in? So there's lots of questions and lots of understanding that you can get. But inevitably, at the end of the day, if we cannot force people who do not want to be helped. And that may come, unfortunately, and it's a scary thought, that might come at a risk.
Thank you. Next question for Connie. Person is saying, we've talked a lot about parents and children, but what about a spouse or a parent not with a mental, with a mental health and substance abuse problem, and more of a drug issue situation?
One piece of it is really similar to what Dr. Chicinelli and Dr. Harrison saying. I often talk about myself as being in the helpless chair. And when working with a spouse, the helplessness that you can feel is real, because we know you don't have to go to very many Al-Anon meetings or CODA meetings to hear that you have a side of the street. So get support for yourself. If possible, find a therapist who understands addiction. But letting go of these expectations is very hard. So I get yourself supported, read, inform yourself, learn from a sponsor. Sponsors have a lot of experience. Listen. If you don't have a sponsor and haven't been to a meeting, listen and watch people. And if you find someone that you think has the maturity that could help guide you, tell them that you'd like for them to listen to you as a temporary sponsor. And that gives you a little bit of space. So all hard.
Thank you. And looking at the questions, so often it is dual diagnosis and self-medication. A person's not going, they won't take the prescription drugs, but they're self-medicating with dangerous drugs. So I'm looking at a question now, and somebody wanted to talk about the dangerous, scary drugs like meth and heroin. Dr. Chicinelli, want to say a few words on that topic?
Yes, I didn't talk about this, but there really is hardly any more where someone just has a mental health condition without having some substance use. And usually it's a concurrent disorder. And with that, there's so many reasons. People will either medicate their symptoms and get into drugs that way, or they will have just gotten into it through their peers and get, kind of a habit going. But nonetheless, we have to be able to treat both and conditions, not one first and the other later, but we have to address both. Otherwise, the person does not get better. And with meth, oh my, such a problem. And I've seen people in advanced recovery still having occasional relapses on IV meth, like once every few years. I mean, it's like, it is so insidious, even for people far into recovery. And then it's not just the meth house down the street, which I had one, by the way. They're no longer there, but the people that take it all the time. And so it is something that has to be addressed, and with patience and understanding. I will say, in response to that, to the other question too, not only for the person who is the spouse of a person in addiction and mental illness, not only to take care of yourself, but try not to act too quickly on making big decisions, because that is going to put you maybe into a reactive mode that is not taking care of yourself. But do get care for yourself. If you have to live somewhere else, or if you have to, you can't be exposed to someone who is seriously using and out of control. You have to protect yourself. Although so many different situations, I'll let Dr. Harrison make comment.
I mean, the first thing that kind of comes to my mind is that oftentimes, if there is a trauma history, substances are a great form of escape and avoidance for a lot of individuals. And so it's a huge uphill battle, because you're taking away, right? You're trying to get rid of a coping strategy that they've developed, right, that works for them and allows them to be free of the pain and suffering that is going on from a mental capacity. So it's correct in that there's this constant duality that's going on, and essentially, I think access to more of the serious types of drugs like heroin and meth, I think definitely allow for a real escapism from the pain and suffering that's going on, right? Oftentimes with alcohol abuse, a lot of these ideas are, when you kind of look into what's going on with individuals, it started very young, and it started as a way of trying to manage a lot of trauma. And so I think that's always a complicated factor. And to the part about the spouse, I think what I said still stands. When you have somebody that is suffering and refuses and is not ready to do anything about it, unfortunately, you can do as much as you possibly can, and then you have to understand your own limits, right? And so that's a challenge. And so you should be in therapy just as much as they should be in therapy.
Okay, another question kind of along the same lines, so I'll stick with you two. Meth use and psychosis. Does the psychosis stop when the meth use ends, or is it more permanent and ongoing?
That's a bit of a tricky conversation. So yeah, I don't know. Do you want to go first?
Well, yeah, it is like the centerpiece. I mean, I spend most of my time trying to figure out if someone had a mental illness before they start using meth, or if the meth is causing a mental illness that didn't exist before.
Yes.
I mean, so everything imaginable takes place. It's very interesting that even cannabis can lead, heavy cannabis use in the young can lead to a schizophrenic like condition, or a bipolar like condition that does not really truly go away. And it is so sad to see that. However, the brain, if people really get into recovery, there's hope, because if they have used a lot, especially in their late teens, early 20s, and they stop, there is hope. There is hope that they'll get somewhat better, but they may be left with a condition.
I mean, substance-induced psychosis, right? Period. Whether it's like through meth or anything. I mean, part of what we do diagnostically is we really have to spend a lot of time trying to figure out what emerged first. And this is where really good clinicians come in and are capable of trying to figure that out. So kind of to my earlier point about the narrative in which you might get asked a lot of questions like, okay, can you remember a time, we look for something called like prodromal symptoms. Like, is there something that was going on where they were isolating at any point? Did you notice behaviors that seemed odd or bizarre? We are constantly trying to figure it out, because the separation of all these different issues is very minute, right? Like when you try to look at it. Now, what does that mean? Well, substance-induced psychosis doesn't always lead to chronic psychosis, right? And sometimes somebody does something once and they have psychosis for the rest of their lives, which is really some of the more tragic, particularly when you have young people, well, actually anybody that's trying to get a sense of use through unfortunate means. The drugs are not clean, right? They're using under the counter ways in which they're trying to get high, and it's causing a lot of other chemical issues that cause an increase in psychosis. And so I would say that I've been at the hospital where we've seen a lot of those kinds of behaviors too, sometimes even with cannabis. And there's a lot of questions that always come up when people are noticing psychosis that's induced by cannabis. But the treatment still inevitably becomes the same, where there is definitely a combination of treatment that has to happen, primarily being medication at the forefront.
Yeah, there's a positive thing that happens, and something that Dr. Harrison had previously discussed, is that we may think we're primarily treating somebody for alcohol or drugs, especially in the case of heroin and meth, and we help them with that, and lo and behold, they get more in touch with the trauma that they didn't even realize they had, or had a faint, and then traumas from different times of their life, like from early childhood and things that happen later in early adulthood or middle adulthood. And then it's like, okay, so now you can look at it this way. Okay, so now we have the ability to deal with those things that were going to erupt some point. And so there's also kind of a joyful outlook on that. If you could say, now that we're getting control of the substance use, we can really start working on your problems.
Okay, thank you for that. I guess our last question for Connie. I'm sort of out there in the community a lot as a school board member, so I meet a lot of families struggling with kids. Sometimes it starts in the high school years, and then broader than that, with my mental health advocacy, meeting people with kids with major mental health issues. And one of the themes I hear often is moms are blamed by,
Mhm.
or sort of turned on. And that's actually how NAMI started, right? A group of moms were blamed for, because their kids had schizophrenia, and the moms were told they did something wrong with their parenting. So,
Yes.
Connie, is that a theme you see in your practice, and kind of a recurring theme with moms being blamed, and how do you help moms?
I don't hear so much. I remember a time when there was talk of the schizoprenogenic mother, or when you saw someone with an eating disorder, the mother would say that she was to blame, and they would say, if you just get out of the way, things will be okay. Here is my thought. If families are part of the problem, they must be part of the solution. When that's possible, when it's possible. And you would not be here in this audience if you did not feel love. And healing, I think I am full of hope because I've seen such profound healing in families. Even sometimes when the mental disorder is fairly intractable, there can be healing in families. But for mothers to carry this, often one of the ideas that grew out of more research around the schizophrenic mother is they actually thought that the moms were more highly attuned and had just seen some of the earlier, Dr. Harrison, some of the prodromal pieces. So yes, this has been something that some of you have suffered greatly under illegitimate blame. Fortunately, we're seeing it, I think. Dr. Harrison, Dr. Chicinelli, if you want to weigh in, I'm seeing it wane.
Well, I have so many thoughts on blaming mothers for things. I mean, it's really,
Yes.
I mean, why not? Let's just add the blame for all the other. Okay, but here's what I can say. When we think about the role of parenting and whether parenting directly is responsible for mental illness, severe mental illness, right? Or abuse, substance, things like that. It is rarely parenting that is creating such huge dysfunctions. Okay.
Yes.
I mean, again, part of so much of what my diagnostic team is required to do when people are in the hospital is figure out what is going on. What is their diagnosis? Why are they the way they are, right? And oftentimes it is not a single event, but a series of experiences that have happened over a duration of time that has led to somebody getting to this point. Most of us follow what we call a biopsychosocial model, right?
Yes.
Meaning that biologically people are predisposed to things. I am sure everyone in this community is well aware of the biology of what goes on, right? Whether it's our genetics, you name it, biologically we might be predisposed. People go through their whole lives having a predisposition to schizophrenia and it never flaring up, right? Because one of the parts of that is the environmental stressors. So sometimes we take the biology of who we are, we mix it with the stressors of our environment, right? The social factors, and we take our psychology and we put it all together, and sometimes we get an output that is not ideal. Sometimes we get people that have dual diagnosis that are very much struggling in life. I think what we don't want to have happen is that we get into like a game of whack-a-mole where every single time we deal with one thing, another thing pops up, right? We have to treat people in a holistic way, right? Where the family is being treated, the individual is being treated, everyone is being taken care of and treated. And that is inevitably, in my opinion, the goal. Blame, right? The blame game, that never works. That doesn't get us anywhere.
Yeah, I would add to that, if you're a loved one of someone who's mentally ill, or a parent especially, don't feel like you did anything wrong.
Right.
Because that's just a bad place to start. You might seek to understand what like to use some empathy into how your child developed, but it's like we have changed from one extreme to the other. We used to think that you're born with a blank slate, a kind of a Freudian view, where everything that you experience is the accumulation of what causes you to be like you are. And we believed that so much, it was scary to go into psychotherapy because, you're going to find out all these horrible things. But at any rate, it's was so much more on the biological side now. Although I'm really interested in developmental issues and how they play a part, but not to the point where you have to feel like you did something wrong.
Thank you all. I wanted to end on a hopeful note, and I think you did that. So we only have a few minutes left. For someone, before I turn it over to Twyla, I want to thank the three of you for giving us your time and your wisdom. I appreciate it. And for our closing words, I'm going to turn it over to the Executive Director of NAMI San Mateo County, Twyla Deppendahl.
Good evening, everyone. And I swear I had no previous conversations with the panelists or Carrie in regards to what I was going to say, because I wanted to share a story of hope. And what made me think was about the small group of parents, as Carrie said, these mothers that were blamed in the mid-1970s, and they believed they could provide a better life for their adult schizophrenics. And they created an organization called Parents of Adults Schizophrenics, and that became the Alliance of the Mentally Ill. And then now we are the National Alliance on Mental Illness for the county. If you haven't seen the video of their journey, it is on our website, and I definitely recommend that you take the time to view that video. So we've come a long way since the 1970s, as we've all know, in brain research and treatment methods. And our work is far from over. I think due to lack of understanding and education, the stigma of brain disorders and mental illness remains. For me, the task seems so insurmountable and daunting. Just with our severely mentally ill living on the streets, in prison, or being transferred to another county for treatment. But just as the small group of parents had hope for a better tomorrow, I have hope that one day we will stamp out stigma and there will be recovery for all. I do believe hope is the cornerstone of recovery. So if you're not part of the NAMI family, get involved. There are many ways to do so. As you being here, you're trying to educate yourself. If you haven't taken our family to family course, I hear it's a wonderful, eye-opening course. Carrie took it, and that is what prompted her to become a board member. So join our board, be an advocate on our advocacy committee, become a program leader and lead a training or lead a support group, volunteer on our warm line. And lastly, something that does not take any time at all is go to our website, namisanmateo.org, click donate. If you're not a member, become a member. Recovery is possible if we all come together, and with your financial support, it brings us just a step closer to making this possible. So thank you. Thank you all. Thank you, Carrie.
Thank you, Twyla, and good night, everyone. Thank you.
Good night.